think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
Okay, we've already started with the discussion topic. We're going to talk about starting off with Bash Bulletin, and the one that deals with the importance of getting the independent medical opinions or examinations when dealing with VA claims.
Right. For the examination? Yeah.
Yeah.
Do you have a
specific
question? Yeah.
Okay. Basically, just kind of an just based on your bulletin itself, how you wrote it up, just basically reports getting, evaluation and what to look for and things like that, and what type of evaluation a person needs, and, what type of doctors and things like that, just general information.
Yeah, well, those C&P examinations or DBQs, are important because that's the way the VA provides nexus. The DBQ and the exam is basically the rating percent, and the nexus is the linkage. So the VA can hurt you on both sides of that. They can downplay the exam, and they can downplay the nexus. So the best idea is be prepared when you go in. And one way to be prepared is to make sure you get as much testing as you can. So, for example, maybe you have a spine injury and it's gotten worse over the years, and you get a repeat X-ray or MRI scan that shows that it got worse, then that's good evidence that the VA has to think about instead of just relying on a physical exam that might be a little bit better, depends on the day and stuff like that. So that helps. That applies for kidney disease and applies for hearing tests and applies for everything. Try and get testing to document what's going on. And then I always talk about trying to find out who the examiner is. Sometimes they have nurse practitioners and PAs, and those guys oftentimes don't have the depth of knowledge. I had a patient last week that had all kinds of problems. Had like some weight loss, had some arrhythmias, and then lo and behold, the lady had a bunch of hair loss in service, and so then later on she ended up with thyroid disease, and you put that all together, she had thyroid disease back in service, and that was all part of that hair loss problem she had. And as nurse practitioners and PAs just aren't able to deal with all those different complicated aspects of the medical part, and so they just take a little piece of it. The VA says, look at the person's, look at their spine, or just look at their hair loss or something. It's kind of like the old story with the elephant. Somebody feels the trunk, and somebody feels the tail, and somebody feels the side of the elephant. They don't realize it's an elephant until they put it all together. So that's good. Also become, it's a little puzzle. That's why I like medicine. Diagnosis is a puzzle. And so then, you got to make sure you have good lay letters. Get those done first. I always recommend getting an IME, a nexus letter. Get yourself a nexus letter before you go to the exam. At the exam, they won't let you enter new evidence. You want to make sure you get that stuff uploaded a few days before, so that way the examiner's got to read it, has a chance to look at it. And if they don't look at it or integrate it, then that's an automatic kind of appealable thing, because it's an error not considering all the evidence.
Let me reiterate that.
I always tell patients. Go ahead.
Dr. Bass mentioned the term IME, folks. That's a very important term. I mean, you've got an IMO, which is a medical opinion, but an IME is a independent medical examination, and that's kind of a little bit higher level. The VA takes a little more weight to that examination versus an opinion. So that's a good point, Dr. Bash.
Yeah, the IME is a big deal. So, I had a guy the other day that had 5 issues, and the VA only did one IME on that person, DBQ. So I wrote my DBQs, and sometimes they take them, sometimes they don't take them. But when I do a DBQ, then it forces the VA to do some DBQs on their side. So they had to go back and examine them for the 4 or 5 leftover issues, and then we can compare notes and stuff like that. So, those IMEs are important. And the X-ray is kind of an IME, and the lab tests are kind of an IME, because all those data points, match up to help the claim get rated. Also, I tell patients also think about the worst case scenario, which is really the idea of a flare-up. The VA has a lot of rules about flare-up, and so the examiner is supposed to talk to you about flare-ups. And so a lot of patients are stoic. They don't want to talk about it. They take pain meds before. I tell them, don't take your pain meds. Also, make sure you talk about the worst-case day with the flare-ups so that the examiner has a chance to do it. And sometimes the examiners will give you leading questions like, you feel great today, or you feel normal, right? And the patient says, yeah, I feel great, or whatever, and so he just writes down normal, when really the patient might have chronic pain. So that's important. Also, I tell them, make sure for the exam they take their crutches, their wheelchair, their cane, or their braces, any of that stuff, because oftentimes the VA examiner might spend 10 or 15 minutes, and if there's no crutch, cane, or wheelchair, he's not going to mark any of that stuff down. So make sure you use all those devices.
I know we had a guy here that was somewhere in one of the VA systems was going in for a C&P exam. He got his cane out of his car and struggled into the VA and went through his exam. He come back out the parking garage and popped his trunk and put the cane in there and got his car and walked off like, there's nothing wrong with him. They used that against him. They had him on video.
Yeah. Yep. I always tell the patients that the exam starts in the car and into the car, because I've had examiners look at people through windows and stuff like that. So, yeah, it's important.
Right.
I also talk about this idea of a walker. Like, I asked patients to use a walker. So, no, he's a walker. And I said, do you go, if you go to Walmart, do you lean on the shopping cart? So, I can't go anywhere without the shopping cart. So, that shopping cart is really a wheeled walker. So, I make sure the patients can describe things in the way that the examiner can understand,
Yeah, that's true. And my wife does. Every time she goes into a store like that, she grabs onto a cart and uses it.
Yeah.
Sometimes I have to too. It depends. Yeah. It does.
Yeah.
It does.
Yeah.
It's a good deal.
The patients don't really think about that as a walker, so that's important. That's one of the big questions on most of the orthopedic DBQs talk about. Do you use a walker, cane, crutches, wheelchair?
What is your opinion on the DBQs now? Do you like the format, or do you think it could be improved?
Well, like I always talked about the fact that they could always be improved, but I've got them memorized now, so I don't worry about the format so much anymore. But I can just go through them. But there's 65,000 codes, and there's only 70 DBQs or so they're kind of a broad brush. There's a lot of stuff. There's a lot of stuff in each DBQ. It doesn't apply to the specific rating. Like, I'll leave things blank, and patients go, hey, man, some of these things are blank. And so a lot of the stuff doesn't even apply because it's just a shotgun, A lot of the, like, say, for the knee, a lot of that rating is based on the range of motion and stability. And there's 8 pages of questions, and it doesn't really match up with the rating schedule, So, and they're confusing. Like a lot of VA doctors, there's places on the spine thing where it asks all this question about spine disease, and towards the end, it asks a question about whether this patient has intervertebral disc disease, and a lot of the VA doctors will check that as no when a patient has it. So the DBQs are confusing to the medical logic because our logic, the way we were taught to do exams and evaluations, is a different order and a different logic pathway. So the DBQs are kind of confusing to the physician, until you get them memorized because they're kind of backwards in a way. They're more of a legal document than they are a medical document, so it's kind of hard to mesh it sometimes.
Well, wouldn't a DBQ be a better, doctor, if it had a place for you to write an opinion?
Yeah, I agree with that. So, you're exactly right. So the DBQ, usually question 2, 3, 4, somewhere there, asks a question about what the history is, and they give you like a quarter of an inch or something. Usually what I do there is I tell the patient, see attach a lay letter and let them write, as much as they want. I have some lay letter samples that talks about, where it happened and what happened in service, what happened now. So there's no space for it. And the same thing for the doctor. Towards the end of the DBQ, many of those DBQs only have like half an inch or an inch space to try and write something. So, like if I do my Nexus letter, my Nexus letter might be 1, 2, 3, 4 pages for each issue. It depends on how big it is. I might have integrated lay letters. I might have integrated some literature. I might have brought in some imaging tests, and so I put in rationale, and I might critique the other doctor's opinion. So all that stuff, there's no way I could put that at half an inch on the page, and if I typed it really small. So, it's almost a setup. It's almost a setup for failure because it doesn't give the doctor any chance to explain himself. So then if you fill the DBQ out and send it in, then the VA says no rationale, and they deny it because there's no rationale. So,
yeah, but when
tricky.
when the CMP examiner he writes or they write a opinion, because usually they say, it'd be a figment of my imagination or something.
Yeah, speculation.
Yeah.
Yeah.
Well, you're right. You're right about that because the VA has their own special website for DBQs. You might have seen some of those. Some of these you see these DBQ forms the ones the VA doctors use look a lot different than the ones that they issue on their website, right?
Yes.
Yeah, I've seen a couple of those. I had one for heart disease here back in the latter part of last year, and they sent me a DBQ. I filed for AFib and arrhythmias, and they sent me a DBQ for hypertension. So I had to get the right one printed off, take it and get it filled out, and then then they went back to the CMP examiner, sent an addendum to her, and asked her the same questions over and over again with an opinion. So that's when the first time I saw their own internal form. It was on. It showed on e-benefits. So I got, what's this? And then I seen what it was. It had a place for an opinion on it.
Yeah, exactly. It says for internal VA use only, and then it has a section that says rationale and opinion, right? It has a big place that talks about prompting the doctor to provide rationale, whereas the other DBQ just says comments or something like that. So, it's kind of it weights it in favor. The other thing, what you just mentioned, was the fact that a lot of the VA doctors do their DBQs online, so they have an online form, so they could type a couple of books in there. There's no limitation on the space they use because it's just an online. Whereas the paper ones are limited, to the space that you have, sort of. Unless you attach something to it, then it might get lost. So it's weighted. The whole thing's kind of weighted in favor of the VA because it's not as fair to the outside doctor doing DBQs.
Yeah, they've got so many DBQs. I think it's a crapshoot. The veterans, they've got enough to do, and then they go through, and the veterans just have to get a medical degree just to find out what's wrong with him.
Yeah. And that's right. A lot of these veterans have complicated disease. That's part of the problem also with the PAs and nurse practitioners. They don't have much experience, or younger, and oftentimes aren't as old as the disease process in the patient, for example. They've never seen anything that extends that long over time. So they don't have a good chance to try and describe what the history is.
Yeah. That's why we get good doctors like yourself and a few other folks, actually can navigate this system. A lot of folks try to navigate it and they can't do it. So, but, if you've been doing it as long as you have, how many years have you been doing this now?
More than 20 for sure. So my first one probably in '86, maybe 30 years now. Time flies.
30 years.
So,
it does, don't it?
Yeah. So, it's crazy. But the other thing is that just a lot of these cases extend back over 30 years, and so the rules that applied 30 years ago still might apply under CUE and so on. And some of the rules that applied 5 years ago may still apply to cases that are pending. So it's nice to have that perspective on seeing the VA change over time, because then I know, kind of how it's supposed to go. And then my thinking might be in line kind of with the DRO, because they're older guys and they've seen the same series of changes,
That makes no sense. For example, the VA will tell you that if you file a claim that's so many years old, your condition has to meet what the regulations stated at the time that happened, not in the today's current world, but it happened, back in 1986 or 85. That's what they look at. They have to use the regulations back in effect at that time. They're covering time periods. So, and they change. They change. Pretty much. They change a lot. They try to they'll try to reduce a lot of stuff, and they'll try to take severities away, and it's just a headache.
Yeah.
So
we talked a lot about. I think one prior shows talked about strain. The VA's gotten on this thing of strain a lot, where instead of giving people arthritis, they call it a strain, which maxes out like 10% instead of a higher percentages for arthritis. So they're kind of using the schedule against the patient. Patients don't realize that they're rated for, lumbar spine strain, but it's limited rating because it's not a full-fledged arthritis.
Well, strain's not really, it's just a strain. It's not, unless you got an MRI showing you got some disc problems and bone problems, that's not a strain. That's arthritis.
Right.
Right.
I think it's a whole different rating.
That's why. Yep. But they also have, in the back injuries, they've got two sets of criteria. They've got invertebral disc syndrome, and then they've got traumatic arthritis. It's rated under two different programs.
Right.
Yeah. You got to be able to separate those two out too, and that makes it, makes it difficult.
Would scoliosis fall into that program of arthritis or rheumatoid arthritis?
Yeah, scoliosis is just a description of a little bit of a curve, like S for scoliosis is kind of like the S curve is the way I think about it. But a lot of people have a little bit of a leg length difference. Nobody has perfect leg length, and a little bit of leg length will cause a little bit of a spine twist, So over time, I had a guy this week that came in and scoliosis, and on the way in, I said that it was was aggravated in service, and he came into service. Like I said, he came into service fit for duty, and then his back was aggravated in service, and it went to the DBA. The DBA judge says I was inconsistent. His sidekick judge. I said, no, I wasn't inconsistent. Scoliosis is a sort of a normal phenomenon, but when he was in service, his back degenerated. It was aggravated over time, so that's totally consistent. You can come in fit for duty with scoliosis. Almost everybody has some scoliosis. So the judge didn't really understand the medicine, and so that's why it was confusing. But so then scoliosis can be caused, pathologic scoliosis can be caused by a lot of things, like you mentioned, arthritis, or maybe a vertebral body fracture, or maybe somebody had a amputation, or had leg length shortening, or something like that. So there's a lot of ways for it to occur. And then something of interest you guys might want to know about. This is very interesting. That I saw this last week that they're using large pieces of parachute cord with some screw bolts into the spinal vertebral bodies, and using the parachute cord on the convex side of the curve to straighten the curve out under kind of the elastic tension of the nylon cord or whatever, something like that. So that's a pretty interesting thing, because usually they always put rods in, these big rods, to try and straighten out scoliosis. And just a little less invasive, kind of a new thing.
That's bound to hurt.
Yeah, the rods are stiff, whereas this parachute cord-like stuff is somewhat flexible, That's a new little twist and treatment. It's kind of interesting.
We'll call that the bungee cord procedure.
Top, right? Yeah. Bungee cord, yeah. It looks like a bungee cord, a big old thick cord, yeah.
Let me ask you, Gerald brought up a good point on scoliosis. Scoliosis, a lot of veterans have scoliosis because a lot of veterans have other issues, But, for example, the spinal cord injury, we'll touch on this later, but people with paralyzed diaphragms, like one side, say if it's the left side, your shoulder on your left side where your diaphragm is paralyzed always elevates. You can see, it on an X-ray. That's how they usually catch it, And over a long period of time where that shoulder stays elevated, that's going to cause you to have scoliosis.
Yeah, anything that throws the body out of balance, whatever's causing that muscle paralysis of the diaphragm is probably causing some paraspinal muscle problems or other types of strap muscle problems. Might be coming from your neck, for example. So then that's going to cause the shoulder to modulate maybe in a compensatory fashion or whatever. Then that's going to change the weight and balance on your spine, and then it's going to start to aggravate everything. So and then you might not use your shoulder right, and that shoulder might go bad because it's being overused, and the wrist might go bad on that side because the same kind of thing. Yada.
What about atrophy in your shoulder if you have a situation? Where it wastes away, like. I've seen some folks, their shoulders elevated like that, but it's half the size of the other shoulder, on the other side.
Yeah.
You know, they'll be wearing a shirt, and on your sleeve will come down on your right spot about next to your elbow, and the left side it goes way down past your elbow.
Right. Yeah, right. So the atrophy, if you don't use something, to atrophies, but also if you have nerve damage or muscle damage, you can atrophy on that basis too. So the VA has a lot of questions in the DBQs about atrophy, and it's a sign you can see, and you got to try to figure out the cause of it. But in the cases like that, a lot of times it's nerve damage that causes the atrophy because the muscle's not being used.
Not being used, or
like the light switch is turned off. Light switch is turned off.
Yeah.
Yeah, not getting any juice.
Mm-hmm. That's true. I mean, it has a lot of effect on people. It's been rough on me. Because it affects my entire left side, but still.
That's a huge problem. Also, you might get contractures from it. So, say for example, you lose your muscle, like your triceps, which straightens your elbow out. Then your elbow's perpetually bent, and then when you have a perpetually bent joint, it can fuse, or the biceps can get tight, and you have contractures. You see a lot of stroke patients or paralyzed patients have oftentimes contractures because they can't stretch for range of motions. So
makes sense. Makes a lot of sense. But, again, I don't think the DBQ has enough, in that situation. I've never actually seen one, for certain like spinal cord and things like that, but I've seen, just different, it's got musculoskeletal issues with your back and bones and the disc and stuff, but it doesn't really cover that much on the neurological side. I haven't seen many of them. You probably have, but I haven't.
Right. Yeah, no, they don't. The DBQ doesn't really cover it. Well, spinal cord, you want to get it, but spinal cord has, some multifunction problems. So, the DBQ is, like I say, mostly musculoskeletal range of motion and so on. But, spinal cord has 10 million fibers going down there, so there's a lot of functions that are going on. So for example, most of those things don't talk much about the neurogenic bowel and bladder part of it, which is huge. The bladder can be like 60% by itself, and the bowel can be 100%. And those are huge problems with spinal cord. They could kill patients and cause infections and septicemia, and skin. Then you get skin breakdowns because you can't feel. Oops, sorry, the DBQ doesn't talk any about the skin breakdowns. Decubitus, bye decubitus, and then the DBQs don't really talk about contractures. From spinal cord, we just mentioned that. In fact, you can have knee, hip, ankle contractures, or you could have heterotopic ossification, new bone formation from little traumas or hemorrhages that you get like in your hip joints. DBQs don't talk about any of that kind of stuff. And they don't really talk about, erectile dysfunction either, which is something that happens with spinal cord a lot that patients have problems with. And then, if you have catheterizations for your bladder, you might get urethral strictures, you might get urethral line pouches. And same thing with the rectum. If you have to do digital stimulation, you might get fissures, or you might get some kind of little neuromas, or you might get prolapse of your rectum. And if you have complications of bladder, you might have surgery with a loop, and you might have to have a colostomy or some kind of a ostomy to drain your bladder, suprapubic catheter. None of those DBQs really talk about any of that stuff. So, you got to really know. You got to really know the medicine. So a patient like that comes down, I dig into it, because a spinal cord patient or a stroke patient or a multiple sclerosis patient, all those kind of have a similar final common pathway. They're going to have bowel, bladder, skin, and ED, and contractures and muscle, blood clots, blood clots in the lungs, your pulmonary embolus. Goes on and on, And the DBQ doesn't even scratch the surface of any of that stuff. So spinal cord guys are really way underrated.
You touched on strokes and things like that. Of course, if you have a stroke, there's a window there that they have to give you. Was it the TPA medicine they shoot you up with?
Yeah,
to try to reverse the effect of the stroke.
There's a lot of ins and outs to that. So stroke, there's a couple types, main types. One's bleeding stroke and one's a non-bleeding stroke. And so that TPA stuff, I was around when they first started using it, PW 20, 30 years ago. So there's a lot of protocols out there, like how much time you go before you can give the TPA or how long you wait. And one thing you don't want to give that anti-clotting stuff to somebody who's having a bleeding stroke. That's one of the big things, because you can make the bleeding worse. So usually they want to do like a CT scan to make sure there's not a lot of blood there. And then there's like a window of time, and actually I was just at a conference this last winter, and they're talking about increasing the window, maybe up to 18 hours or even a day later, a lot longer than what we used to think. I used to think like in the hour range, now it might be in a day range. So, and that's the whole justification for the rapid transit and the Maryland, shock trauma kind of systems that are all over the country, trying to get people in quickly. So that's one thing you can do, is you can put the TPA or something like that directly in the vein. That helps. Or you can put that stuff inside a catheter and squirt it right into the clot, if you know where the clot is, if you find the clot on the MRI scan or angiogram. And then besides that, you can also put these little like corkscrew things that go into your catheter. You can actually corkscrew in and pull the clot out that way if you find a big one. Or you can go with a snare, like a little snare that you might use to catch a rabbit with or something, it's a little wire loop. You can take that, and sometimes you can wrap that around the clot and pull it out. So it's all about trying to get blood reperfuse the brain. My analogy is if the sprinkler head goes out in the grass, you're going to have a dead circle of grass, right? So the same thing in the brain. If you can fix that sprinkler head so that the blood in this case, could perfuse the brain, then you're going to have a lot less problems with the stroke that we had before. And this stuff is evolving. The type of medicine is evolving, how you give it, how long you give it, how fast you give it. Thank you all for listening. That ends this show. And now I'm going to zoom off.